This topic is pain assessment. Nociception is the normal functioning of pain and sensory pathways. When there is tissue trauma, inflammatory mediators are released, resulting in sensitivity to stimuli in the area of injury. And specialized receptors, or nociceptors, transmit the pain impulse to the brain, or the CNS, where the pain is then perceived via the afferent neurons. And efferent neurons and neurotransmitters modulate that pain impulse. So what do we mean when we say afferent and efferent? Well, afferent means away from the body, or ascending to the CNS. Afferent carries information from the sensory receptors in the periphery to the CNS. Analgesics target these afferent pain pathways to prevent sensations of pain from reaching the CNS. And efferent, think exit or descending, since the efferent pathway takes information from the CNS to the periphery for an action. Like if you were to touch a hot stovetop, the efferent pathway tells the periphery to pull that hand off the heat. There are different types of pain that our clients may experience. Acute pain may result from an injury, surgery, or an acute illness that causes sudden onset of pain, and it has a short duration. Chronic or persistent pain has a longer duration than acute pain, lasting several months or longer. Chronic pain normally results from a disease process like cancer or arthritis. Chronic pain that is well controlled may have periods of breakthrough pain, which is moderate to severe pain that lasts anywhere from 3 minutes to 30 minutes, or sometimes even longer. Breakthrough pain can have unpredictable onsets. Referred pain is pain that is felt in a location different from where the cause is, and it may occur in clients with visceral pain, which we'll talk about in a minute. For example, a client with pancreatitis may experience referred pain from that upper abdomen to the left shoulder blade. The different types of pain may be impacted by the different pain pathways. Nociceptive pain results from tissue damage from a laceration or broken bones. This is the normal processing of stimulus, with stimulation of peripheral nerve endings called nociceptors. These respond to non-opioids and opioids. Visceral pain originates from deeper internal structures, for example, organs, and differs from somatic pain mainly in the mode of transmission. The client with visceral pain may feel dull, aching, cramping, or throbbing pain, or they just may feel sick. This pain can be localized or not. An example would be appendicitis, where everything viscerally is inflamed, and it kind of may feel similar to irritable bowel pain. Somatic pain is a type of nociceptive pain that originates from the skin, muscle, bone, or connective tissue, like a paper cut or sunburn. This pain is sharp and well localized. Somatic pain originates in the periphery from nerve endings. Other examples can include pain from the second stage of labor, or even a stubbed toe. Somatic pain responds somewhat to opioids. Neuropathic pain is caused by nerve trauma or injury. One example is nerves that fail to function properly due to damage from illness, which may include diabetic neuropathy and foot ulcers, or distal limb pain even after an amputation, or pain from dermatomal origin like shingles. Neuropathic pain can cause burning, electric, or tingling sensations, but it doesn't always respond to opioids. However, it does respond to adjuvant analgesics like gabapentin. Let's talk about how we can assess a client's pain level. There are a lot of different pain scales available. You want to make sure the pain scale you use is appropriate for the client with consideration to their age, language barriers, hearing or sight difficulties, and cognitive delays. The pain scale gives a way to consistently assess the client's pain from nurse to nurse, and you want to make sure you document which pain scale you're using and the client's response. The numerical rating scale asks the client to rate their pain from 0 to 10, with 0 being no pain and 10 being the worst pain the client has ever had. And it's really important to emphasize that because pain is subjective and perception can vary greatly. We can also use visual analogs like the Wong-Baker scale, or ask verbal description of the pain using the OPQRSTU, and we'll go over these concepts later in this video. Another tool we may use to assess pain is the Critical Care Pain Observation Tool, or CPOT. This tool is used for nonverbal clients, including clients that require mechanical ventilation. For the subjective assessment, the nurse will obtain a detailed description and assessment of the client's pain. One way we can do a thorough pain assessment is to think of the alphabet with OPQRSTU. O, onset. When did the pain begin? When does it occur? How long does it last? Did it result from an injury, surgery, or is it chronic? And how long has it lasted? For a client with chronic pain, is this a different pain than what you normally experience? P, provoking or palliating. What makes it worse? What makes it better? Maybe it hurts more after I eat, or it gets better after I apply heat. Q, quality. What does it feel like? Is it aching and dull, or stabbing and sharp? If it's neuropathic, is it burning and shooting, or nociceptive, aching and throbbing? R, region and radiating. Where is the pain? Does the pain radiate? And get specific. Point to where the pain hurts. Sometimes clients will say, my stomach hurts, but it's actually pain coming from the pelvis. And ask about chest pain. Does it radiate to the jaw or down the arm? S, severity. Using those pain scales we just talked about. What is the intensity on a 10-point scale? And at what number is it at its worst? Is it a 10 when it's at its worst? Or what about the least? Is the lowest baseline number a 3, or can we get it to a 0? This helps with communication of the pain for the client, and this can also help us to determine if our interventions are effective or not. Time and treatment, T. When do the symptoms start? What medications help? Maybe it starts in the morning when I wake up, or it's better when I take aspirin before my walks. The client may know what has been effective in the past. U, understanding and impact. What do you believe caused this? What's your understanding of the pain? And how is the pain affecting your activities of daily living? Is it impacting your sleep? Is it impacting your walking, your ambulation, or maybe your work and self-care? When completing an objective assessment, we need to remember that pain is highly individualized. Each client has their own experience of pain, which may be affected by their previous experiences, the current situation, the psychosocial aspects of their pain, and it could be influenced by their cultural background. While symptoms may vary depending on the client, the nurse may expect to observe diaphoresis, hypoventilation, vomiting, oliguria, joint swelling, muscle spasms, or maybe some limited mobility. When we're assessing a client's pain, there are also nonverbal indicators of pain that we can observe, and some pain scales measure these and come up with a rating. Like facial grimacing. This is especially important for clients when they can't speak or have a breathing tube. Or abdominal guarding if the client has abdominal pain, maybe tense leg or arm movement in response to pain. Restless activity, like when your shoulder hurts and you keep moving around to get comfortable. The client may be crying and inconsolable. And how the body naturally responds to pain with hypertension, tachycardia, and urinary retention. There are not any absolute measures of pain, and nurses have to be open-minded to clients who don't show expected indicators of pain. For instance, we can't just assume a client has no pain if they're sleeping, laughing, or watching television just because they don't look like they're having pain. For pediatric clients, the nurse may consider using an age-specific pain tool, including NIPS, Neonatal Infant Pain Scale, where we assess the facial expression, for crying, breathing pattern, the arms and legs, and the state of arousal. NIPS assigns points in each of these categories and then totals them. This can be used for preterm and full-term infants. FLAC, the facial expression, leg movement, activity, crying consolability scale, is used for pediatric clients between the ages of 2 months to 7 years old. An example of what is assessed in the FLAC scale includes facial grimacing, tense leg movements, restless activity, crying, and inconsolability. The Wong-Baker Faces Pain Scale is used for clients 3 years of age or older. This scale has the client point to a face that represents their pain the best. Some of these scales also have actual pictures of children with different facial expressions to make it easier to choose. Older adults may have difficulty using number scales to describe their pain because they have become more tolerant to pain over time, resulting in inaccurately low reports of pain. And medical providers may have a false perception that pain is an expected part of aging, causing inadequate treatment of pain. Also, clients with impaired cognitive functioning like dementia may have a hard time accurately reporting their pain. For these clients, we can use the PAIN-ADD, the Pain Assessment in Advanced Dementia Scale, which assesses for changes in breathing, vocalization, facial expression, body language, and consolability. Nursing interventions for pain assessments. We want to use an age-appropriate pain scale, and assessment frequency is dependent on situation and condition. Watch the cues from the client. We want to assess pain before and after interventions, but follow-up assessments may be done at different times after administration depending on the intervention route. Like for IV medications, we may reassess after 5 minutes, but for oral medications, we'll reassess after 30 to 60 minutes. Another example is pre-medicating for a dressing change that could cause discomfort for the client. We want to pre-medicate prior to doing a painful procedure on a client so we can assess 30 minutes before the dressing change, then administer the medication, Continue assessing while doing the dressing change, and then after the dressing change is complete. Use the client's own words in documentation. By using their words, we're taking away any subjectivity in our interpretation may cause. We want clear, accurate documentation for continued reliable pain management. What works and what doesn't. Does something make them feel more sick or uncomfortable? Does something cause a side effect that's worse than the pain itself? And validate the client's pain with their active listening and empathy. Their pain is their experience. We want to remove any of our own bias with a thorough pain assessment. We want to establish a trusting relationship with the client so they feel like they can be truthful in their reporting. Some clients may act stoic because they don't want to bother the nurse, or they just don't want to complain. Use your observation skills as well. Do they look like they're in pain? And if this happened to you, would you be in pain? A client with chronic pain may express their pain differently, and we don't want to assume this is what you always have, because that may not be true. Is this different? How is it different? Remember that cultural background can influence a client's expression and perception of pain. We want to be respectful of that. For the client who believes expressing their pain is a sign of weakness, maybe wait until you can ask while they're alone and not their family isn't in the room. And for that client who's openly expressing their pain, we wouldn't want to think they're exaggerating. We never want to assume. We always need to ask about their pain with open-ended questions and allowing them time to respond. Determine the client's support team and coping strategies for pain. What has worked for them in the past? And does the presence of a support person help reduce anxiety, promote comfort, and decrease pain? Pharmacologic management is guided by the client's pain level. We're going to be using a multimodal approach, using analgesics from different medication classes with different underlying mechanisms of action combined with non-pharmacologic interventions. This allows us to use lower doses of each medication because they're working together. And this actually generally results in better pain management for the client. Types of analgesia including opioids, non-opioids like acetaminophen, and non-steroidal anti-inflammatory drugs. Adjuvants, which can be used alone or in conjunction with other analgesics. These are usually developed for other conditions, but they decrease pain by enhancing the effects of pain medications. Like anti-seizure medications and antidepressants are the first line to treat neuropathic pain, or medications that complement opioids, like gabapentin. For non-pharmacologic interventions, we can alternate hot and cold application, or use distraction, like music or watching a movie. Maybe some guided imagery or biofeedback, which helps the client control automatic body functions to reduce sensations of pain and increase coping with pain. It's often used for clients who have chronic pain. Sensors are placed on the client's body that detect changes in temperature, heart rate, and so on. Changes in these things trigger a response in the monitor to help the client learn to control their responses to stimuli from pain. And lastly, for non-pharmacological interventions, we can encourage deep breathing or provide a massage.